All right, so we're setting the stage today for something super critical on the MCCQE1, and that's community-acquired pneumonia, or CAP. Ever wonder what those red flags are that scream pneumonia even before you reach for a stethoscope?
That's a great question. It's such a common presentation, so understanding those initial clues is key.
Exactly. So let's start with a foundational understanding. What is CAP actually? How would you define it for the exam?
Okay, so basically, CAP is an acute infection of the lung parenchyma, but the crucial part is that it's acquired outside of hospitals or extended care facilities. That community-acquired part is really important.
Spot on. It's that distinction that guides our initial approach. Now, when a patient walks in, what are the absolute key symptoms you'd be looking for that strongly suggest CAP?
Well, the big ones are usually fever or chills, a cough that can be productive or non-productive, shortness of breath, which is dyspnea, and often that sharp pleuritic chest pain that gets worse with breathing.
Yes, those are the cardinal symptoms. Beyond the direct symptoms, what important historical elements are you always asking about when you suspect CAP? These are the things that help you risk stratify and choose treatment later.
Oh, definitely comorbidities like COPD or vaccination history for flu and pneumococcal, and crucially, any recent antibiotic use within the last 3 months.
Perfect. Those historical points are gold for the next best steps. Now moving to the physical exam. What are the most telling findings you'd expect to see or hear that would point you towards a CAP diagnosis?
I'd be checking for tachypnea, increased respiratory rate, and tachycardia. On lung auscultation, localized crackles are a huge clue, and if it's more advanced, you might hear bronchial breath sounds or egophony, plus dullness to percussion over the affected area.
Right, those consolidation signs are classic, and we can't forget decreased oxygen saturation as an objective measure. So with those symptoms, history, and physical exam findings, you've got a strong suspicion. What do you think we look for next in the diagnostic pathway?
After gathering all that clinical data, I'd say the next step is definitely confirming the diagnosis.
Precisely, that's what we'll dive into next, the initial investigations. All right, so we've identified the signs and symptoms suggesting CAP. Now, to confirm our clinical suspicion, what would you say is the most appropriate initial investigation for suspected CAP, especially thinking about the MCCQE1?
That's a classic MCCQE1 question. The most appropriate initial investigation for suspected CAP is definitely a chest X-ray, or CXR.
Exactly. It's the gold standard, even with all our advanced tech. So, what exactly are we hoping to see on that CXR to confirm our diagnosis?
We're looking for a new infiltrate. It could be lobar, interstitial, or even cavitary. That's the key radiographic hallmark of pneumonia.
Spot on, and it's not just about confirming pneumonia, right? The X-ray also helps us pinpoint the location and extent of the infection and even rule out other conditions that might mimic CAP.
Right, but it can't always tell you the specific bug, which is important to remember.
Precisely. It confirms pneumonia, but not necessarily the cause. Now, beyond the XRA, what other initial investigations are commonly ordered, and what vital information do they provide?
We'd also get a complete blood count, or CBC, which might show leukocytosis with a left shift, indicating a bacterial infection. Also, renal function and electrolytes are important.
Why are those renal function and electrolyte results particularly crucial, even though they aren't directly diagnosing the lung infection?
They're essential for assessing hydration status, baseline organ function, and critically for calculating the CRB-65 score, which helps with risk stratification.
Excellent point. Now, let's consider those severely ill patients, or those with specific risk factors for resistant pathogens. What additional investigations might we recommend for them?
In those severe cases, like if they're heading to the ICU or have risk factors for resistance, we'd add blood cultures to identify bacteremia, and also urinary antigen tests for Legionella pneumonia and Streptococcus pneumonia.
Fantastic! These specific tests help guide targeted therapy when the patient's condition demands more precise management. It's about moving from suspicion to confirmation, and then to a deeper understanding of the severity to set up the next steps. All right, so we've moved past confirming the diagnosis with a CXR and all those initial investigations. Now, determining patient risk and setting the appropriate care level is absolutely crucial. What if I told you that a patient who seems fine could actually be at high risk for complications from CAP just based on a few simple criteria?
Wait, really? That sounds incredibly important for clinical practice and definitely high yield for exams like the MCCQE1. How do we figure that out?
Exactly. This is where the CRB-65 score comes in. It's a widely used clinical prediction rule to assess the severity of community-acquired pneumonia and guide those critical management decisions, like whether a patient needs to be treated as an outpatient or admitted to the hospital.
Okay, CURB 65. I remember hearing about that. What does each letter stand for, and what are the specific criteria we're looking for?
That's a great question. Each letter represents a specific clinical factor, and if present, it scores 1 point. So C is for confusion, meaning disorientation to person, place, or time. The U is for urea, specifically if it's greater than 7 millimoles per liter.
Got it. So confusion and high urea level are red flags.
Precisely. Then R is for respiratory rate, where we're looking for a rate of 30 breaths per minute or higher. The B stands for blood pressure, indicating a systolic pressure less than 90 millimeters per mercury, or a diastolic pressure 60 millimeters per mercury or less.
Those sound like pretty significant vital sign abnormalities.
They are. And finally, the 65 just means age 65 years or older. So it's a quick snapshot of multiple risk factors combined. If you had a 68-year-old patient presenting with new confusion and a respiratory rate of 32, what would their CURB 65 score be?
Age 65 plus is 1 point, confusion is another, and respiratory rate greater than 30 is a third. So that patient would have a score of 3.
Spot on. Now, what does a score of 0 to 1 tell us about the appropriate management decision for a patient with CAP?
With 0 to 1 points, they're considered low risk. That means they're typically suitable for outpatient treatment, which is great for patients and healthcare resources.
Exactly right. Now, let's say a patient scores 2 points on the CURB 65. What's the next best step in management for them?
A score of 2 indicates intermediate risk. For these patients, they generally require either a short hospitalization or closely supervised outpatient treatment. It's a bit of a gray area where you might need more observation.
And for a patient with your earlier example, scoring 3 points or even higher, say 4 or 5 points, what does that mean for their care?
Well, 3 to 5 points is the high-risk category. These patients usually require inpatient hospitalization, and if they hit 4 or 5 points, they're very likely looking at potential ICU admission. It's a clear signal for intensive care.
Absolutely. This score quickly helps us triage and determine the most appropriate level of care, which is vital for patient outcomes. Understanding this allows us to move directly into initiating appropriate empirical antibiotic therapy, leading into tailored treatment strategies. All right, so we've identified how crucial the CURB 65 score is for figuring out the right level of care. Now, the next logical step and a major exam point is initiating appropriate empirical antibiotic therapy. Let's start with a classic MCCQE1 scenario. What is the first-line treatment for a previously healthy patient with CAP who has no recent antibiotic use?
Okay, if they're previously healthy and haven't had antibiotics recently, for outpatient management, I'd lean towards a macrolide, like azithromycin, or maybe doxycycline if macrolide resistance is a concern, right?
Exactly. You've got the core options there. Azithromycin is usually preferred, but doxycycline is a solid alternative. Now, here's where it gets a bit trickier, which is what our hook mentioned. What if that same outpatient patient has comorbidities like diabetes or has used antibiotics within the last 3 months?
Ah, that changes things. So for those with comorbidities or recent antibiotic use, we need something stronger or broader, I suppose. Is it a respiratory fluoroquinolone like levofloxacin or a combination of a beta-lactam and a macrolide?
Spot on. Both are first line for that group. Either a respiratory fluoroquinolone, levofloxacin or moxifloxacin, or a beta-lactam like amoxicillin clavulanate or cefuroxime, plus a macrolide. That combo provides broader coverage. See how important that history of comorbidities or recent antibiotic use is? It completely shifts the initial treatment.
That's a huge distinction. It really highlights why the history is so vital. So what about when a patient needs to be admitted but isn't quite ICU level, say a CURB 65 score of 2?
Great question. What is the first-line treatment for an inpatient, non-ICU management scenario?
For non-ICU inpatient, I'm thinking similar to the high-risk outpatient, but maybe intravenously, so a respiratory fluoroquinolone or, again, a beta-lactam plus a macrolide. Are specific beta-lactams recommended here?
You're on the right track. Yes, the options are the same in terms of drug classes, a respiratory fluoroquinolone or a beta-lactam such as ceftriaxone, cefotaxime, or ampicillin-sulbactam, combined with a macrolide. The route would indeed be typically IV initially for an inpatient. Now, for the most severe cases, a CURB 65 score of 3 to 5, requiring ICU management. What's the baseline empirical therapy there?
Okay, ICU is serious, so we need robust coverage. Is it still a beta-lactam plus a macrolide, but perhaps specific ones?
Precisely. The core is a beta-lactam. Ceftriaxone or cefotaxime are common examples, plus a macrolide, or sometimes a respiratory fluoroquinolone can substitute the macrolide. But with ICU patients, we also need to consider specific risks. What if there are risk factors for Pseudomonas aeruginosa?
Wait, really? Pseudomonas is a whole other beast. So for that, we'd add an anti-pseudomonal beta-lactam like piperacillin tazobactam and an anti-pseudomonal fluoroquinolone or an aminoglycoside, plus the macrolide.
You've got it. That combination covers all the bases for Pseudomonas. And what about if there are risk factors for MRSA, like recent hospitalization or previous MRSA infection?
Then we'd add vancomycin or linezolid to the regimen to specifically target MRSA. Wow, the antibiotic choices really cascade depending on the patient's risk factors and severity.
They absolutely do. Understanding these nuances for empirical therapy is critical, not just for the exam, but for real-world patient care. It's all about tailoring the treatment to the individual. We've covered a lot of ground on initial management, but what happens if things don't go as planned? Next, we need to consider some potential treatment pitfalls and what complications can arise. All right, so we've talked a lot about the initial diagnosis and treatment of CAP, but even with the right steps, things can sometimes take a turn. So thinking from an exam perspective, what is the most likely complication of CAP?
That's a great question. Even with appropriate treatment, CAP can lead to significant complications. I'd say respiratory failure requiring mechanical ventilation is definitely a big one, especially in severe cases.
Absolutely. Respiratory failure is critical. What else should we be on the lookout for? Because it's not just about the lungs, right?
Exactly. We also need to consider systemic issues like sepsis and septic shock, which is that severe inflammatory response leading to organ dysfunction. And then there are localized complications in the chest, like pleural effusion or empyema.
That's right. An empyema where you have pus accumulating in the pleural space would absolutely require drainage. What about something more contained within the lung tissue itself?
That would be a lung abscess, a localized collection of pus. And let's not forget about acute respiratory distress syndrome, ARDS, which is a really severe inflammatory lung injury, causing widespread capillary damage and impaired gas exchange.
Those are some heavy complications, for sure. Bacteremia is another one, and ultimately, in the most severe cases, death. It underscores why early and accurate diagnosis and treatment are so crucial. But what if it's not CAP at all? What are some key differential diagnoses that can mimic CAP, making things tricky?
You know, that's where clinical skill really comes in. Acute bronchitis, for example, can present with a cough, but importantly, it won't show a radiographic infiltrate on CXR, which is key for pneumonia.
Right, that CXR finding is vital for differentiating. What about patients with pre-existing lung conditions?
Asthma or COPD exacerbations are big ones. They'll have worsening respiratory symptoms, but typically there's a known history of the chronic condition. That helps distinguish it from a new onset CAP.
And then there's heart failure, which can really throw you off with dyspnea, cough, and crackles. How do you tease that apart from CAP?
With heart failure, you'd often see orthopnea, paroxysmal nocturnal dyspnea, and on CXR, usually bilateral infiltrates indicative of pulmonary edema, rather than the localized infiltrate of pneumonia.
That's a critical distinction. What about something acute and potentially life-threatening that might also cause chest pain and dyspnea?
You're thinking pulmonary embolism, aren't you? It presents with acute dyspnea and pleuritic chest pain, but here's the catch. The lungs often sound clear on exam, and the CXR might be normal or show subtle abnormalities, unlike CAP.
Exactly. And we should also consider things like atypical pneumonia caused by organisms like mycoplasma, which tend to have more systemic symptoms and less dramatic CXR findings. And of course, aspiration pneumonitis or pneumonia, especially in patients with impaired consciousness, often presenting with findings in dependent lung segments.
So basically always keep a broad differential in mind, even when CAP seems likely, to avoid missing other serious conditions. It's about looking beyond the obvious.
Right. It's about considering the bigger picture to ensure we're always providing the most appropriate care. We've certainly covered a lot today, from complications to these tricky mimics.
It really emphasizes the importance of a comprehensive diagnostic approach, not just for CAP, but for any respiratory presentation.
All right, so we've really unpacked CAP from every angle. Now let's distill all that information into the absolute essentials for anyone tackling the MCC QE1.
Yes, that's what it all comes down to, right? What are those crucial takeaways we absolutely must remember?
Exactly.
First up, when a patient walks in with those classic CAP symptoms, fever, cough, shortness of breath, your brain should immediately scream CAP. And the most appropriate initial investigation to confirm that suspicion—
Chest x-ray, no question. That's the gold standard to see that new infiltrate.
Spot on. Once you've got that radiographic confirmation, the next best step in management is all about figuring out how sick the patient is. This is where the CURB-65 score becomes your best friend.
Right, for risk stratification, confusion, urea, respiratory rate, blood pressure, age 65 or older. Each point guides you on whether it's outpatient, inpatient, or ICU management.
Precisely. Understanding that score is paramount for deciding the level of care, and directly tied to that decision is, of course, the first-line treatment, which antibiotics to choose.
That's where you have to consider comorbidities, any recent antibiotic use, and the severity, as determined by CURB-65. It's not a one-size-fits-all.
Nope, definitely not. Whether it's a macrolide for a previously healthy outpatient or a combination of beta-lactam and macrolide for someone in the ICU, tailoring that empirical therapy is key.
And even with the best treatment, we have to keep an eye out for potential complications like respiratory failure or sepsis. It's not just about starting treatment, but monitoring the whole course.
Absolutely. And let's not forget the importance of differential diagnosis. As we just discussed, there are many conditions that can mimic CAP symptoms, so always keep that broad perspective.
So basically, suspect CAP with symptoms, confirm with CXR, stratify with CURB-65, tailor your antibiotics, and then stay vigilant for anything going wrong while also consider other possibilities.
You nailed it. That's the high-yield summary right there. Mastering these points will truly set you up for success on the MCCQE1 when it comes to CAP questions.
It really consolidates everything. I feel much more confident about tackling those questions now.
Fantastic. Keep these key principles in mind as you continue your preparation, and you'll be well on your way to